Welcome to yet another presentation by the Royal College of Surgeons of Edinburgh in this series of webinars for medical students who are undergoing disruption to their education due to the ongoing coronavirus pandemic. Some of you are back to university, I know, but some of you are still having restrictions to how you work. Today, we have interesting, sometimes considered obscure, but very important topic, and that is the management of pheochromocytoma. This is important for more than one reason, and my friend and colleague and internationally renowned endocrine surgeon Radu Mihai, who is a consultant surgeon at the Oxford Radcliffe Hospital, the University Hospital of Oxford, is going to talk to us about it. There will be a question and answer session at the end of this, and you can pose your questions online, and Mr. Mihai will answer them, hopefully, at the end of the presentation. In addition to that, this week on Thursday, we have the management of carotid artery disease, which is the next in our series. So without much ado, to my friend Radu.
Mike, thank you very much. Good afternoon, everybody. I'm very sorry I can't see any of you, but these are the times we live in. My talk today about pheochromocytoma is built with a hope to raise your interest about endocrinology and such conditions. Maybe it's too little surgery and it's too much basic science in it, but was done so on purpose. If you have more questions at the end, I'll try to expand a bit more. So the talk is called Pheochromocytomas. I like to go back to the forefathers because it's important to know that Charles Mayo, one of the brothers who set it up, the Mayo Clinic, was the first one to operate one such patient in the United States. In Europe was a man in Switzerland who did so. But what I liked about the Mayo paper in 1927, when he first operated one, he called it a tumor of the retroperitoneal nerve. We need to go back and understand that at that minute, in early 20s, people didn't know anything yet about adrenaline. They knew about the adrenal gland, but Mayo believed that this tumor was in fact joined to a nerve. And this will come in a minute to become very important. But it's interesting to see how the vision was there in this Charles Mayo's operation that he published in German. Then again, to look at the history, part of the pheochromocytoma history is very much linked to is like a presidential disease, because President Eisenhower had a very complicated life with many cardiac events throughout his political career. He was the first to benefit from a defibrillator. He had first treatment with beryllium tosylate, was offered the first ever use of an intra-aortic balloon pump, because all through his life was supposed that his heart and blood pressure are the big problems. He had 8 heart attacks and 14 cardiac arrests throughout his life. In the end, at his autopsy, somebody found a pheochromocytoma. So he shows us that whatever how famous you are and whatever how famous is the institution that treats you, the diagnosis can be missed, and maybe we're only seeing the side effects of the condition, but the disease itself is never treated. Well, all starts in embryology. So you might remember from the neural crest, you have this sympathoadrenal lineage, and then under the influence of glucocorticoids, some of these cells end up as the chromaffin cells in the adrenal gland. The other cells from the same family will go to be the sympathetic neurons. So these chromaffin cells in the adrenal gland are considered to be a modified postganglionic sympathetic neuron. So they are like a neuron, but they don't communicate with the others. They represent about 1/10 of the weight of the adrenal gland, and they are known to be able to synthesize and certainly to store and release in the bloodstream noradrenaline and possibly some adrenaline. The base of these cells is to have these granules that contain the hormones that have to be released. And the concept of a granule inside an endocrine cell that needs to fuse with the membrane and be released is very much in keeping with the same cellular machinery that it's present in a neuron. So there are lots of things in common. It's the embryology and it's the way these cells function that makes them very closely related to the neural system. So one is supposed to, when they look down the electron microscopy images, to see the adrenal granules and the noradrenaline granules as different entities. They differ in size because the ones with noradrenaline are larger, and they differ in number because in a pheochromocytoma, it's expected that the vast majority of them will produce noradrenaline. The chemistry, it's too much to remember the details of it, but nevertheless, noradrenaline is the first precursor from which an enzyme called PNMT, phenyl N-methyltransferase, creates the adrenaline. And that enzyme is present in the adrenal gland, of course, but it's also present in the periphery. So a lot of this adrenaline, it's in fact released in the periphery by working out the enzyme that transforms the noradrenaline released from the adrenal gland. So as a definition, a pheochromocytoma, it's a tumor that arises from these chromaffin cells, and it's in the adrenal gland, and it produces these catecholamines. The counterpart is called paraganglioma. It's an identical tumor when you look down the microscope, but this one has grown in extra-adrenal tissue, in those sympathetic neurons distributed across the body. And so the paraganglioma is the sort of pheochromocytoma outside the adrenal gland. And in some papers, the two terms are used to, like being equal, but they're not. The other thing that is interesting is that this pheochromocytoma, it's obviously active, it's from the adrenal gland. Paragangliomas in the lower part of the body secrete the same chemicals, while through some unknown exact explanation, those in the neck and in the upper part of the body are non-secreting. The ones in the upper part of the body can be along the vagal nerve at the base of the skull. A lot of head and neck surgeons will be involved with them, they don't produce the same chemicals, but when you look down the microscope, they have the same granules and the same physiology. So you wonder what is missing. Well, that's a question for you. Maybe one of you will answer and will send me a paper in the future for me to read and be educated. So these are things that remain unclear. The old books introduced this mnemonic of 10% related to the pheochromocytoma, was called the 10% tumor, because it was supposed that 10% of cases will be familial, 10 will be bilateral, 10% will be extra-adrenal, 10% in children, and 10% malignant. It's good for an exam or for your memory games, but is not really confirmed in reality to be quite 10%. The most convincing error, it's in the genetics of this condition, because up to a third of these tumors are in fact related to one of the many genes described to be involved in the development of such tumors. And whichever gene it's possibly the cause of this disease differs based on whether it's a familial condition, if the patient has unilateral or bilateral tumors, and whether it develops tumors outside the abdomen. Time is flying fast, and so I might not go through all these slides, but one of the important factors involved is this VHL gene, the von Hippel-Lindau, that needs to be hydroxylated in 2 positions to be able to join properly and to act. And this has been the source of a Nobel Prize attributed last year for medicine, of which Professor Peter Ratcliffe from Oxford was one of the authors. And how this gene interacts with the pheochromocytomas, it's yet to be fully explained in some patients, but nevertheless, mutations in this gene gives you a risk of developing pheochromocytomas as much as it gives you the risk to develop renal cancers or hemangioblastomas. Then it's a whole story about succinyl dehydrogenase, which is an enzyme that is needed for the hydroxylation of this proline on the VHL gene, and mutation in this gene has more recently been described to be present in patients who have extra-adrenal tumors or malignant tumors. So there is a model whereby some of the tumors have a neural signature based on mutations in the red gene and neurofibromatosis, and others come with this hypoxic signature related to the VHL and the succinyl dehydrogenase. This is the most important slide that I wanted to spend time and to make sure we're not losing it. Is the way you pick up these patients, is the way like you should not miss these patients. It's all based on the history that the patient will give you. Everybody that arrives to our unit for an operation is frustrated that it took them many years to be diagnosed and then another year or two until they get referred for treatment. In those initial years, patients will describe episodes, spells, attacks of headaches, palpitation, sweating, abdominal pain, and doom and gloom. Each of them can occur in many other patients, but when they occur as a group of symptoms, they should already raise the concern about this. These episodes can be spontaneous, patient has no control over it, or they can be triggered by physical exercise, straining, lifting, and some rare occasions by foods that contain tyramine. And in many of them, initially it's labeled as anxiety or dismissed or dispels of psychological or even psychiatric symptoms before a biochemical assessment is being done. It's likely that as you will become yourself consultants in charge of your own practice, you will see more and more adrenal incidentalomas, some meaning tumors picked up by chance on a scan done for another condition. And when you investigate that further with biochemical assessment, you realize that this radiological abnormality, it's in fact a pheochromocytoma. So an example of this would be many patients needing MRCP before lab chole. That picks up an adrenal tumor. The question is, could that be a pheochromocytoma? And the third way to pick these patients up is when you investigate a member of a family with a known genetic mutation that is known to be associated with a pheochromocytoma, and for whom a biochemical screening is organized on a regular basis to assess whether they have developed the tumor and therefore the need to proceed with treatment. The diagnosis is based on measuring metanephrines, either in the urine or in the blood. Metanephrines are products of the metabolism of inside the cells, where noradrenaline, it's transforming normetadrenaline, and adrenaline, it's transforming metanephrine. So it's a bit of a tongue twister, but nevertheless, the family of these chemicals is called metanephrines, and this is what we measure today. So in 2020, this is the base of the diagnosis. Few years back, people used to measure in the urine the catecholamines, the noradrenaline, adrenaline, and dopamine levels. But they were raised only on a day when they had an attack. So the patient was supposed to collect urine on a day when they have the symptoms. And that was at times unreliable. With the metanephrines, with the new method that is currently in use, these levels are raised all the time, whether or not the patient is symptomatic on the day of the test. This VMA, it's archaic, it's history. I don't even want to tell you what VMA stands for because you could just delete it. It was vinyl mandelic acid, but that is of historical interest, of no clinical application at the present time. If the biochemistry is good and convincing, showing a diagnosis of pheochromocytoma, you need to try and demonstrate where is the pheochromocytoma. And one starts with cross-sectional imaging, most of the time a CT scan. If so, it is chosen an MRI. The pictures I show you, it's an MRI just to demonstrate the right-sided pheochromocytoma with this appearance of cystic changes within it. It's very characteristic if the tumor shows these big cysts within it to be suspected to be a pheochromocytoma. There is then functional imaging, whereby the patient is injected with this chemical called MIBG, a long word standing for meta-iodobenzyl guanethidine. This is uptaken into the granules of the chromaffin cells, and it shows on a scan. This scan is from our last patient who had a tumor, an extra-adrenal tumor, a paraganglioma here in front of the aorta. The red dot here, it's the compound in the urine, in the bladder. It's of no significance. And this patient also has uptake in the neck because he's an SDHB patient with the two tumors, one in the neck, non-functional, and one in the abdomen, functional. We just removed this a couple of weeks ago, and now he continues to be monitored for the one in the neck. Because as I said earlier, the danger is the abdominal one that produces these chemicals. Why do we need to identify and treat these patients? Is because if they discharge by chance too much of these catecholamines, they can have a dramatic cardiac event. They can have a stroke, they can have a heart attack, they could potentially die of excessive release of adrenaline and noradrenaline from these tumors. To avoid this happening, once the diagnosis is confirmed based on the biochemical test, they need to start adrenergic blockade. And that it started with drugs that control the alpha receptors. Because for some pharmacology reasons, if you block the beta receptor in these people, you will make their blood pressure worse. So they have to start with alpha blockade. And throughout the last few decades, this old-fashioned drug called phenoxybenzamine has been used. It's not licensed for anything else. It's only used in patients with pheochromocytoma to provide this adrenergic blockade. And once this is well established, you offer them propranolol for the beta blockade. Depending on what university you are at, depending on what hospital you work, depending on what country you might end up working, in some places, rather than using phenoxybenzamine, people can use doxazosin or calcium channel blockers, as it is commonly used in France. We live to a debate as we speak whether adrenergic blockade is necessary, and for the sake of the lecture today, the answer is yes. If somebody can do it without, it's a risk, it's their own decision, and it's no point at this level to have this debate. The take-home message is that pheochromocytomas needs blockade with these drugs before you proceed to do the operation. Because before the operation, the patient ideally reaches a good control of the blood pressure with systolic of about 131/80, and with a heart rate well controlled and 60/70. And when these drugs have done their job and the blockade is well in place, it's safe to proceed with the operation. The operation is a laparoscopic adrenalectomy for the vast majority of them. Michel Gagnier was the first man who did one in US in the early 90s, and since then this has become the standard technique. It's no point for this lecture today to show how you do the adrenalectomy, because most of you, hopefully, will just be involved in identifying the patients. For the few who might be interested on how you do this operation, of course, there would be other occasions to discuss more about how the operation is done. What is interesting is that for most of you, a review in BMJ declared that the average GP, for example, can only see one case in his career. Well, you'll be interested to know that for the audit, the national audit that is maintained by the British endocrine surgeons, pheochromocytoma represent a third about of the workload. So of those operated for adrenal conditions, about a third have pheochromocytoma. Yet out there in the public, the tumor is supposed to be rare enough to be described by that BMJ review from a few years ago as a one-in-a-lifetime encounter for most GPs. This is my last slide. It shows changes in blood pressure in people who were well blocked. And this is a person who had two pheochromocytomas, one on each side. So the blood pressure would start well as expected. When you start to handle the tumor, there is an up and down of the blood pressure in response to handling the tumor and the drugs that the anesthetist use. Then it's a little bit more steady as you finish one side and you start the other side. And when you operate on the second side, the blood pressure still goes up and down. So these changes in blood pressure occur even in people that are well blocked. Imagine how bad this might have been without any of those drugs in place. So it's a very interesting condition. if I could just return to my initial slide with suspicion, this is the take-home message. This is the one that you should have in front of you. If the history of a patient suggests these spells coming together, you should investigate more with more direct questions, never dismiss it, try to avoid any more of the trigger factors while a biochemical assessment is put in place, and then consider discussing with a colleague how best to prove this. It will be a great reward if you identify one such patient who can miss having a disaster heart attack or stroke based on an undiagnosed pheochromocytoma. And even more dramatic, it's a pheochromocytoma in pregnancy. A young woman with a pheochromocytoma going into labor could be a deadly combination for the mother and the child. So this has to be avoided at all costs. So whichever specialty you might get into in your future years, this is something to have in mind in people who present with an interesting history or with a suspicious scan. I'll stop here and I'll take some questions from you. Thank you very much for today.
Radu, as always, fascinating. I've always found this subject challenging as well as intriguing because of the rarity, but also the consequences of having missed a diagnosis. And there was a very pertinent question that came right at the end, and that is, what does a surgeon do if they stumble upon a tumor that ends up being a pheochromocytoma that's undiagnosed at the time of surgery?
So first of all, as a matter of practice, if that operation is done by somebody who should be indeed doing adrenal surgery, its own training will involve making sure that the possibility of a pheochromocytoma has been excluded before starting the operation. If you start an operation for a completely different indication and the patient becomes unstable, most of the time on induction of anesthesia, that is a very stressful time for the patient, and this is when the blood pressure will go sky high. The operation should be abandoned and the patient waken up and the diagnosis considered and the appropriate management put in place. One should not proceed without the appropriate backup. Please, Mike. Is this the question?
I think that's the key, isn't it? That you should just back out and
yes, stop, abandon, and reconsider if that's the right place for the patient to be and the right team to look after the patient.
Exactly the point we should get across. Going back to the diagnosis itself, Richard from Oxford asked very early on in the discussion. Anxiety. So anxiety is one of the common presentations. How does that differ from the anxiety that you would see in a pheo? And I think that leads to what you said about the other features.
Yes, anxiety on its own might be completely a psychiatric disease. Anxiety, it's a disease of the young generation, I'm told. I don't know. There are lots of people more and more asking help for anxiety. But the problem is to have anxiety plus many of the other things, not on its own. Headache, it's a very common condition that other people look. Migraines, it's a completely different story. Palpitations, it's full in cardiology. But they need to come together. They need to express the other symptoms before you start to think pheochromocytoma. It's no point scaring patients that present already with anxiety, saying, oh, I think you have an adrenal tumor. That they need, your history has to pick up on other elements that as a package are suggestive. On their own, have no power for that.
And how important is serum metanephrines versus the 24-hour urinary metanephrines? Because there are a few questions.
From my point of view, it's all a matter of access. So plasma metanephrines go to a central laboratory in Newcastle. So you need to wait for the sample to travel. It needs to go to be spinned down, to be frozen. It travels frozen from your hospital to Newcastle. Newcastle does all the results, and you have the results maybe in 2 weeks. For us in Oxford, I send urine because I can have results in the lab in few days, like 2-3 days. if I really need it. So the technology to do the urine and the blood metanephrines varies a lot, and therefore each hospital has its own little arrangement of where these samples travel.
So the answer to that really is that they're both as important. If you
They are both as important. For the convenience of the patient, plasma, it's easier. So for those, rather than collecting urine, currently we moved from collecting urine 24 hours in doing on a spot urine. And that is a massive progress. The paper was published this month in European Journal of Endocrinology by the Oxford endocrinology team. We are not part of that effort, but I very much admire their work. They looked at about 6,000 samples as a urine spot or 24-hour urine collection. And the message is you can send the spot urine and it's still going to pick up the suspicious ones. And if the spot urine is suspicious, you confirm with 24-hour urine.
That's my lesson for the day then. Thank you.
Yes. So it's easy. In the clinic, you just send it straight away. No need, because it's cumbersome to collect urine 24 hours.
The last question we have time for, it's been a great discussion, but the last question is, if you've got a Pheo and that's the cause of the hypertension the patient has, and you remove the tumor, does that cure the hypertension?
Oh, that's a very interesting question. It's most likely it will make the blood pressure much better. For another condition that drives hypertension, which is Cone syndrome, which is hyperaldosteronism, people made the score to say that if your blood pressure has been for less than 5 years, if you're slim and you need less than 3 drugs, you will be cured of hypertension. So for these people, the hypertension spikes will go away, whether they have a background hypertension, just as so many other 16 million UK citizens have hypertension apparently, then it's a second question, but they will not have those dangerous rises at blood pressures 200 plus 240. The highest number recorded was 340 in a patient operated in a hospital nearby, who was abandoned exactly along the lessons that we talked earlier on. So you can see values like you've never seen on the machine. You can see values that might not be measurable with your normal blood pressure machine.
And the other interesting question is, why are the symptoms paroxysmal? Why do they come in waves? Yeah.
Because we've learned from when people were measuring just catecholamines that the tumor somehow discharges large amounts intermittent, not constant. Maybe parts of the tumor gets necrotic, and this is why they end up on an MRI looking cystic. Maybe people pressure on the tumor, like straining on the toilet. It's also very clearly, very easy to understand when the pheochromocytoma is in the bladder, and then you have these symptoms each time you go to pass urine. So any mechanical stimulation of the tumor will make it release some. And we see that when we operate on it, that if you touch it much, the blood pressure goes very high, and then we have to stop a bit and restart the dissection until the vein that connects the adrenal with the cava or with the renal vein, it's clipped to isolate the tumor from the rest of the circulation.
It's so interesting. And is there any place for embolizing the drainage of the veins to reduce that side effect, or it's just the blocking?
Well, to embolize the adrenal vein is very difficult. People embolize arteries. People don't quite embolize veins. It's not an easy position, and I don't see how that, I don't know, it's not been attempted. People try to embolize adrenal tumors for other reasons, and they failed because the arterial supply to the adrenal comes from many little branches from all over the adrenal, from the top, from the bottom, from the back in the retroperitoneum. And so the arterial source cannot be embolized to kill the tumor, and the venous drainage cannot be blocked short of going to put a clip across and remove the tumor.
And that's essentially because the adrenal has so many pathways of draining.
Indeed, predominantly a lot of arterial supply, but also the venous drainage is quite extensive, and therefore is no point attempting interventional radiology for this.
So the take-home message is you need to block them properly.
Block them and send them to somebody who's done this before. There is an effort in this country now to limit adrenal surgery for pheochromocytoma to hospitals who do about 12 per year, 12 adrenal operations, not 12 pheochromocytomas. And though the numbers doesn't sound like much, I would be very surprised if it will be achieved, because a lot of them are still done in many places that don't do enough. And that is the challenge for the coming years.
Indeed, indeed. And the last question, Radu, and that is, how do you know you've blocked a patient sufficiently, and when is it safe to proceed to surgery?
Well, that is a big debate in this world. The slide I had earlier was showing the criteria that our own anesthetist has introduced, and we've been trying to stay. So you check that the systolic, it's never jumping over this. The patient monitors the blood pressures at home. And you check these standing and sitting blood pressures, because for each of us, without the medication on board, there is a significant change in blood pressure when you move from lying flat to standing straight away. And you want to block these changes well enough with the medication to take away any of the sympathetic drive. So you try to encourage the patients to take as much of the phenoxybenzamine as they can tolerate, and still maintaining a physical ability to go and do their jobs and be part of their family. When you had enough phenoxybenzamine, your blood vessels in the nose change and you get a blocked nose, and that's a very reliable sign to say your alpha blocked well enough. And that's the challenge on interacting with the patient a lot before the operation, to ensure that on their day-to-day measurements of these blood pressures, you don't see any more spikes, and that the average systolic is in the range that I mentioned.
That's wonderful, Radu. Thanks again. It was really informative and engaging.
Well, I hope it's useful for them. And once again, the aim was to make you buzz and to make you motivated about the many questions that are still left out there. My slides with the genetics are over the top, but maybe for some of you will be interested.
And who knows, someone might want to be an endocrine surgeon in the
future. I'll be so happy. Come and find me. Super happy.
And just to remind everybody, Thursday, same time, we are talking about the management of carotid artery disease. This is a hugely important topic and a common problem that is related to the prevention of stroke in this country.